was explaining, and it almost felt like, right, the only option is a knee replacement, take it or leave it. And I can remember saying to him, but I'm only 50 years old, is that not too young? It's like, no, that was the only option. So that's the reason I went with it. There was no other options given to me. And I like to think that I'm an intelligent human being. I'm realistic, I know that things go wrong, but I think I wasn't given the information to make the informed decision. The concerns weren't validated. I didn't feel valued. I actually felt like I was a pain and I was taking up too much time. So again, not heard and not listened to. It felt very much like, the consultant, the surgeon had done his job, and it was a big tick, but it didn't matter how that decision and how that operation had impacted on that patient.
What you heard there was exactly how the system we have designed has worked. I'm Raju Ramesh. I'm an orthopedic consultant. I've been a clinician for over 35 years. In my time, I've done thousands of operations. I want to look back and ask the hard question. How many of my patients have actually said yes to the operation because they understood me? Did they simply nod because they were too polite to interrupt me? I really want to reflect on that. Nicola here was simply a tourist in a land called healthcare. We, doctors, clinicians, worry about biology. We look at MRI scans, look at statistics, risks, benefits. But Nicola, as a patient, is worried about pain, thinks whether she can actually play with her grandchild. We shout facts across the case, tell them about probabilities, risks, benefits, but Nicola wants to know whether she can really get back to her normal life. When Nicola nods to me and says yes to an operation without understanding the implication, it is not informed consent. It is a polite surrender. Now, every one of you in this room are motivated. You want to deliver the best for your patient. We all have our own mandate. We have our charter. We want to work to that. But in the front line, when I'm seeing patients with 10-minute slot for a patient, when I'm a bit late, unrushed, and the patient is fearful, I do not really believe that the shared decision making happens often. It digresses to a clinician decision telling. We expect our brilliant clinicians to deliver a high level of care to our patients, but we give them a 20th century tool and expect them to deliver a 21st century care. We are asking them to describe probabilistic risk using a PDF paper which is written to a graduate level. The hard truth is that up to 10% of patients who undergo a knee replacement are not satisfied with the outcome. 1 in 10 who have the operation don't feel that they benefited from this procedure. They walk away from that feeling unhappy and dissatisfied. The National Joint Registry last year's data tells us that we have done 134,000 knee replacements. That means that nearly 13,000 patients did not feel that they received the value. The cost for a knee replacement is about £9,400. The cost for the NHS is £128 million just for the one operation. Just imagine all the other conditions, diabetes, mental health, women's health. Our patient simply nods in silence to the clinician telling. What we really need to do is to flip this. We need a Rosetta Stone, which will convert the medical input into a human output. Needs to be visual, because pictures are the universal language. It needs to have equity, should not be barred or limited with literacy or other characteristics. It needs to be interactive. It should give you some information about what matters to you, rather than, oh, on an average, this person would get that. The dividend for getting a tool that will help us to do this is when the patient really understands what it means to undergo an operation. At least 5% of them will actually decide not to go through the procedure. At least 5%. There are some literature says up to 30%. What it really means then is that the patient decides, I do not want to have this operation. They walk away from that. Not because we denied it, it's because they've understood what it means to go through a procedure. And in financial terms, for one trust, by enforcing a good shared decision-making practice, you could save £250,000. Shared decision-making is perhaps the most effective efficiency drive we have, and we have not embraced it well. I just want you to ponder over this picture. I want you to strip your title away. You're not a professor anymore. You're not a doctor. You're not a manager. You're not a CEO. You're not a CFO. You're a patient lying down on that bed. And that's your vision. You see the drip dropping down, monitors beeping. I'm actually closer to lying in that trolley than taking a scalpel after long years of time. Many of you would probably have been a patient. In that moment, when I'm lying down, all my knowledge, all my medical experience is not going to save me from making me feel small. The important thing is that I'm actually scared. Not about the operation, but about the silence. What I really want is a system where I can actually interact with it. In this day and age of digital and AI predictive algorithm, we are still handing over pamphlets to our patients to make a life-changing decision. I think that needs to change. What I really want is to have the ability to choose what I want at my own terms, not accept what has been given to me by the team. I do not want to be a passenger in my healthcare journey. I'd rather be a pilot. Actually, I don't want to be a pilot. I want to be a first officer. I want to fly with a pilot and have my journey done. How can we actually achieve this? We can stay silent and continue giving out leaflets and expect our patient to be silently nodding to our discussion, or we can be our own architects. We can be our architects of the matrix. We can build an infrastructure of understanding where the voice of future will be heard. What it does is that it restores dignity, equity, choice, responsibility, ownership, and it moves the system of compliance to a system of understanding. Don't just take my word for it. Listen to Nicola when she underwent a second operation.
Just amazing, and amazing because he listened and he valued what I had to say, and he validated my concerns. He didn't make me feel silly. He didn't make me feel that he was a surgeon and he knew best, and I was just the patient. Which is, he talked to me, he listened to the concerns, and he cared. And not for 1 minute did he ever say, "You've got to have it done," or "We've got to get it done." If I'd have had a tool like this, I would have felt that was a conversation starter. You know, there was a tool there was some discussion to have about where I am currently, where I could get to if I had a certain procedure, where I would find myself if I went to the other extreme and had the operation. I would have been able to ask about the risks. I would have been able to ask if we could try something else before we got to that final operation. If this had been available then, I could have sat with you as my surgeon and said, okay, so we've got all these choices here, that's not available, that might be available. But bearing in mind my other health issues, how would this work with that medication? We could have had a proper discussion. Amazing, amazing.
So, I started the talk with a question. Whose decision is it anyway? I really want this to be a decision that is taken together. We need to build a system that we really want to inherit as a patient, because we will be a future patient as well. Thank you very much.